Now.
Okay, sure.
So this time, the Neurotrauma Society of India, in association with the All India Ophthalmological Society. So this topic of this webinar is often very important and often overlooked. Traumatic injuries of the visual system from a multidisciplinary perspective. So we have excellent panel of speakers. Dr. Harsh Devda, he is additional professor in Department of Neurosurgery in Nimans, and he will speak. He will cover optic and oculomotor traumatic injuries. Then we have Dr. Susank Balerao. He is working as consultant in Santilal Sangvi Cornea Institute and L.V. Prasad Eye Institute, Vijayawada, and he has been associated with the US also in various fellowships. So he will cover the traumatic injuries of the eye. And then we have Dr. Arun Srivastav, who is professor in SGPGI Lucknow, and he will cover endoscopic and transcranial optic nerve decompression. Then we have esteemed panel of panelists, Dr. Edmond Jonathan, who is professor and head in CMC Vellore, and Dr. Vijay Parihar, who is professor and head of neurosurgery in Jabalpur, Super Specialty Hospital. So I think Dr. Harsh, you can start, you can take over and you can start.
Sir, we don't want to wait for Arun sir, sir. Arun sir, I think.
Sir has not joined.
Sir, joined.
I have joined.
Yes. Sir, okay, sir. I'll start, sir.
Yeah, you can start. I'll stop. You can
start. Yes. Sir, I hope the slides are visible, sir.
Yeah, it's visible.
Yes. So I'll start, sir. So I'm going to speak on the traumatic neuropathy, that is optic and oculomotor nerve injuries. If you can picture a person, a young man who is at a wheel of a two-wheeler, you would have gathered mostly everything about the epidemiology. Most of these injuries are due to motor vehicle accidents. And most of these injuries to the nerve are intracanalicular, because that is the only fixed portion of the nerve between two movable portions, or that is the intraorbital and the cisternal portion of the nerve. Those are the movable portions, and the intracanalicular portion is the only fixed portion of the nerve. And hence the injury at this point is the most common. Overall incidence of traumatic optic neuropathy ranges from 0.7 to 2.5, and the incidence is higher in case the patient has craniofacial fractures. Most of these injuries will have concomitant higher grade head trauma, that is 2.3%, along with traumatic optic nerve injuries. Now, this complicates the situation quite a lot, because most of these patients might be comatose at the time when they present to you, and may not present with visual loss as their first complaint. If we can understand the optic nerve or the orbital anatomy, to be precise, we will understand how this injury happens. The superior orbit or the roof of the orbit is formed by the frontal bone. The lateral wall is formed by the sphenoid bone. The infraorbital rim and the floor of the orbit is formed by the zygoma and the maxillary bone. And the most important part, that is the maxillary or the ethmoid bone, forms the medial wall of the orbit, which is usually the thinnest part of the orbit and usually is the one which gets fractured. There is something called as a Cook's grading of traumatic nerve injury. This is the Cook's grading of traumatic nerve injury. In this, the grade that is very, very important to us is grade 2, where there is no fracture and the vision is better than PL negative, but it is less than or equal to 6/60. This is the grade which we are going to treat most of the time. Above this, if there is no fracture and the vision is better than 6/60, patient can be managed conservatively. Grade 3, if the patient has a fracture or is PL negative, the prognosis becomes extremely poor. And grade 4, if a fracture is present and patient is again PL negative, the prognosis is dismal. So if the traumatic optic nerve injury can be divided into either the direct form or the indirect form. The direct form is where a fracture has happened, the sphenoid is fractured, or there is a medial wall of the orbit which has fractured and has caused optic nerve avulsion, laceration, or bony transection. The prognosis in this is extremely poor, and severe irreversible loss has mostly happened in these cases. Indirect injury is the one where there is just transmission of force to the optic nerve, leading to swelling, intraneural hemorrhage, or secondary edema being developing in these cases. And the prognosis in these cases is quite good, and 40 up to 60% the variation is there in the literature. These patients may actually improve. Usually, if you have to understand it in one line, the pathophysiology, it is that you have approximately 48 hours before ischemia turns into infarction. After that, you are not actually treating the injury, you are just treating its ghost basically. If arterial obstruction happens, irreversible infarction will set in between 24 to 48 hours. And this is the reason why most of these cases, most of the series that I will explain to you later, they will have a good prognosis if they are operated early. A single RAPD is the one sign which an unconscious patient will not hide from, and you must learn to trust it absolutely. If RAPD is present, that is relative afferent pupillary defect is present even in a comatose patient, this should alert you of a mild traumatic optic nerve injury, which may be absent in certain cases. If in these cases, the first and the most important investigation, apart from the ophthalmological examination, is the fundoscopy, because it will rule out any orbit or the orbital related injuries or the fundus related injuries, which my next speaker will be dealing with, which may be vitreous hemorrhage, retinal detachment, choroidal rupture, pre-existing atrophies. So that treating these cases might be futile, because they may have a completely different prognosis in these cases. Fundus may be normal in these cases, especially in posterior nerve injuries, and the disc swelling is only present if it is anterior to the central retinal artery entering into the optic nerve. CT scan is thin cut CT scan with orbital cuts is very, very important, because if the sphenoid bone is fractured, then the prognosis is dramatically different as compared to normal bone being present there. MRI has to be dealt with caution, because many of these cases, as I will explain to you in the examples later, may have metal lodged into them, especially in penetrating injuries, and ferromagnetic objects are obviously a contraindication for MRI. VP, OCT, and Doppler are other investigations which may be done in these cases. Now, this was a very good editorial that was written by the AIMS group. One of the most important things that they had told was that the 2/3 of the traumatic optic nerve injuries are associated with significant head injury. And RAPD, if present, is pathognomic and may be symmetrical also. And fundus may be normal in most of these cases. One of the most important findings that came out of their study, which I will discuss after this, is that even if steroid therapy was given, or if patients were conservatively managed, or if surgical decompression was done, the amount of improvement in all of them was almost similar. However, the cases suitable for each approach, that is for conservative, steroid, and surgical decompression, are completely different from each other. So you have to choose the right approach for the right case, and the outcomes may remain the same in most of these cases. The AIMS algorithm in currently is that steroid, if no severe TBI or contraindication present, that is if no traumatic brain injury is not severe, then steroids are given, and VP and examination is done every 2 to 3 days for 3 weeks, and if recovery is present, they conserve these patients. If, however, the visual acuity remains static, less than 6/60, then surgery is done between 1 to 2 weeks. This is approximately 70 year systematic review of literature on traumatic optic nerve neuropathy. And you will understand that why this topic is so difficult, because even after analyzing so much, there was not much which came out of this. They analyzed the International Optic Nerve Trauma Study, which showed that untreated patients had 57% improvement, steroids had 52% improvement, and surgery had 32% improvement, which is approximately the same and did not have much of difference among the two. There was no level 1 evidence supporting routine steroid use, and obviously in cases of traumatic brain injury, as we know of the crash trial, steroids are actually worsens the prognosis rather than improving it. Erythropoietin was one drug which had shown level 2 evidence in some of the studies of show improvement, but this is still under investigation and is not standard of care as of now. So there are other emerging drugs which are coming, that is brain-derived neutropenic factor TNFA inhibitors, but these are all under still investigation. So there was no significant differences among all of these cases. What are the indications of surgery? The surgery itself will be covered by the third speaker. And what are the indications? Indications are bone fragments or hematoma compressing the optic nerve, orbital roof fracture, no visual improvement or progressive deterioration on high-dose steroids, evidence of optic nerve damage on preoperative VEP, residual vision at presentation, that is perception of light or better. If a concurrent neurosurgical procedure is being carried out, then obviously if optic nerve decompression is to be done, then that can be taken in the same setting. If, however, complete optic atrophy has happened, or there is no perception of light in this patient within 48 hours, or if there is a direct traumatic optic nerve injury that is crushed or transected nerve, these patients are relative contraindications because the result may not be good. So what are the various approaches? The most common expected approach in these cases is endoscopic endonasals, because these patients that we are selecting for endonasal approach are the ones which do not have a fracture or have a small undisplaced medial wall fracture of the orbit. This allows for almost 180 per degree decompression of the optic nerve. The superior 180 degree obviously remains, and there is no external scar. Transcranial approaches is best for lateral fractures of the orbit and the temporal bone on the frontal bone, and this will also lead to the decompression of the entire optic canal along its entire circumference. Transorbital is also one route which has been told that can be used for these cases, and approximately 192 degrees of optic nerve may be decompressed using this technique. This is an image of an optic nerve decompression. This is the optic nerve which has been completely deroofed. This is the annulus of Zinn, and this is the dura above it. Basically, if you can understand this from a transcranial or a transsphenoidal route, you will realize that there is a lateral OCR that is usually seen when we do the endoscopic endonasal route, and we have to start decompressing the optic nerve from that this thing landmark, and then go medially up to the annulus of Zinn. Now, cutting the optic nerve sheath, this has been controversial. Some authors advocate it, some authors do not advocate it. I will get to this evidence now. So this is the optic nerve. This is the operative technique. This technique will be explained in much more detail by the third speaker. To understand this, again, the lateral OCR is seen, and there is a lateral medial antrostomy, maxillary antrostomy that is done. This is the optic nerve. This is the optic nerve. This is the ICA. This is the normal view that you get while doing the endoscopic transsphenoidal surgeries, and this is the tuberculum sella. You start decompressing the optic nerve from lateral to medial, and the medial part where the optic strut comes is where the bone will be very thick, and you can use drill for that level. And this is the approximate look, annular. Once the optic nerve sheath is cut, this is the view that you will get of the optic nerve. Now, coming to the most controversial part of this whole situation, whether the optic nerve sheath incision has to be done or not. This is a large study that was done from AIIMS. They had approximately 35 patients of which in which optic nerve sheath incision was done, and 22 patients in which optic nerve incision was not done. So what happened was, pre-1999, 35 patients had optic nerve sheath incision done, and then 3 patients developed CSF pneumonia, and then sheath incision was stopped. But when they were analyzing these patients, they realized that the optic nerve sheath incision led to better outcomes, and hence again it was restarted after some time. This in itself tells you that there was so much of debate of doing optic nerve sheath incisions or not. However, in wherever the sheath incision was taken, the improvement was much better as compared to where the incision was not taken, approximately 50% versus 33% in these cases. So their conclusion was sheath incision and osseous decompression should be done, especially in those cases where there is no fracture present and it is indirect or traumatic optic nerve injury. One more important factor that they had was that even if the surgery was done as late as 63 days up to 3 years also, the results were quite okay, and the sheath incision has to be done superior-medially because the ophthalmic artery may be inferior-medial, and if you cut at that level, the ophthalmic artery may get injured in these cases. So there is also a lot of debate regarding what is the timing of surgical intervention. The optimal window, after reading a lot of articles and coming out of it, it remains 24 to 48 hours, because the amount of patients that got 6/6 vision was maximum these. However, this is not to say that if the patients have not improved and they come back after 7 days or 10 days or even weeks after the injury, these patients should not be offered surgery. These can be offered surgery, and in some cases they might actually improve after this treatment also. So these are the visual improvement rates in all of the series that I could find on the internet as of now. And you can see that the series ranges from anywhere between 32% to 83% in all of these cases. And the recovery, the most important factor for recovery in these cases remains good vision or residual vision at the time of presentation, that is PL positive to at least 6/60. Above this, if you have done the surgical intervention within 72 hours, VP was normal. It is an indirect traumatic optic nerve injury. There was no optic canal fracture, and there was some recovery on steroids. These are good prognostic factors for optic nerve recovery in these cases. So obviously, every surgery or every operation has its set of complications. CSF leak remained one of the most common complications with optic nerve decompression. To circumvent this, many of the authors, what they have done is they give an Valsalva maneuver at the time of the sheath incision, and if the patient has occult CSF leak at that time, then the repair is done with either facial ATA or a mucosal graft. Internal carotid injury obviously is possible, but extremely rare, because you can see the compression or the impression of the IC in these cases. What is to be remembered in these cases that these are cases of trauma after all. So many of these cases might actually have fractures which have gone into the ICA before the surgery has been done, and these may be unearthed at the time of doing the optic nerve decompression, and the IC injury may not be caused by you as such, but may have been uncovered after you do the optic nerve decompression. Worsening of vision was found in one of these cases, but most of these cases are already PL positive, so there might not be much change after the surgery. Other infections such as meningitis, that is infection or CSF rhinorrhea, which is delayed, are always there, and these have to be dealt with as in any surgery. This is the algorithm that is present for deciding the optic nerve injury treatment. That is, ophthalmology assessment and CT scan is done. If it is a direct traumatic nerve injury, surgical decompression is to be done within 72 hours. It may be done either by a craniotomy or by an endoscopic approach. If it is indirect traumatic optic nerve injury, you give steroids. If the visual acuity starts to improve dramatically, then you just continue medical management with close follow-up. However, if the visual acuity remains normal or does not improve in these cases, or even starts worsening, then these cases are considered again for surgery in these. So this is one of the cases that we had received, which is a penetrating optic nerve injury, where almost a 15 centimeter steel rod was injured, was inserted into the skull of this worker. And obviously, in these cases, we could not get an MRI done, and only a CT and CT angio was done in these cases. ICA control was taken in this case. However, there was no ICA injury. The prognosis of the optic nerve remained poor because there was complete transaction of the optic nerve and the chiasm in this case. So the patient had a bilateral visual loss. However, we were able to extract this, and this was the recovery MRI, which showed that complete injury of the optic chiasm was there. There is another factor which decides optic nerve surgery in these cases, that is the orbital roof fracture. If this orbital roof fracture has happened, then probably craniotomy or a TNL approach is better as compared to an endoscopic approach in these cases. So if for optic nerve, if I was to summarize, it is always diagnose first. RAPD is the best diagnostic factor. Surgical threshold is only when there is some improvement or no improvement or worsening after steroids. In indirect traumatic optic nerve injuries, the results are better. The best time to do it is within 72 hours. It is not the gold standard after all. The approach is decided by the type of injury which has happened, either lateral or medial, which will decide on the craniotomy or the endoscopic option. Sheath incision is not routine and may be decided intraoperatively if you feel that there is an intrasheath hematoma, or this patient might improve with sheath incision in these cases. To move from optic nerve injury to another important nerve, that is the oculomotor nerve, this is a much more forgiving nerve, if I may say so, because the incidence after craniocerebral trauma is almost 1.2%, and it may be isolated in some of these cases. Most of these cases again occur in young males, and the peak age remains the same. These injuries are divided according to the 5 segments of oculomotor nerve, that is the nuclear region or the mesencephalon, the midbrain or the fascicular region. These two are low risk but poor prognosis of optic nerve injury. The subarachnoid space remains the shortest, yet the most vulnerable segment, because it crosses the petroclinoid ligament in these cases. And the mechanism remains that most of these injuries, the brainstem tends to go down, and the oculomotor nerve will get sheared over the ligament. The best portion or the best prognostic portion remains the cavernous segment and the superior orbital fissure segment in these cases. If there is a root avulsion or at the midbrain exit, then these injuries will not improve. There is a very good chance that you might see such an image on the CIS 3D imaging, that is the optic nerve is completely avulsed from the midbrain as compared to the opposite side, and these cases will absolutely not improve, and so there is not much that we can do for these cases. If, however, the patient has an intraneural hemorrhage, or there is nerve edema, or there is focal compression due to a sphenoid fracture, these are the cases which lie under the purview of operative cases in these injuries. This is a case of sphenoid fracture which had caused a superior orbital fissure to be compromised, which was ultimately decompressed, and the oculomotor nerve improved after that. One very important factor in these cases is that if a patient of mild traumatic injury comes to with pupillary involvement, it is extremely important that you do a vascular workup in these cases, that because a pupillary involvement in a third nerve injury is for a neurosurgical case is related to an aneurysm unless proven otherwise. This is extremely important because this may be missed and may cause catastrophic complications at a later date. So, what are the imaging strategies in these cases? CT non-contrast, thin cuts with orbital cuts being taken with the standard MRI T1, T2 flare, and MRI CIS 3D or Fiesta, if possible, can be done in these cases. There is a special sequence of MRI that was developed in Nemans for the optic nerve injury, which I will get to in one go. This is again one more example of the optic nerve being injured at the mesencephalon. Now, there are various modes of injury or levels of injury that might you already know. That is, it might be either neuropraxia, axontomesis, root avulsion, or compression in these cases. And the prognosis remains excellent with neuropraxia and good with sphenoid fracture. However, it remains poor with axontomesis or root avulsion in these cases. Recovery rates. Now, this is a very important slide because the recovery rates of ptosis, that is external ophthalmoplegia, is the best as compared to internal ophthalmoplegia, that is pupillary recovery is the worst. So if the patient has ptosis, you can counsel the patient that the patient will have good recovery of the ptosis. However, if you understand this, that once the ptosis recovers and the external extraocular muscles have not yet recovered, this actually leads to a worse problem for the patient because it leads to more diplopia as compared to if the patient has ptosis and cannot use that eye even with a good visual acuity in these cases. So this is one of the papers that one of the algorithms we had taken out of Nemans. So this is a very specific high resolution contrast enhanced MRI that is done for optic nerve injury. This was approximately 6 cases that we had collected of oculomotor nerve injury in Nemans. All of these cases were either road traffic accidents, and most of them were very young individuals. The concept was that will be a disruption of the blood-brain barrier due to trauma, and this will lead to gadolinium enhancement when you give with a small voxel size. If you see, the voxel size is almost 0.4 millimeter. So this can be picked up while doing the MRI in these cases and can be used for prognostication of these cases. Most of these cases were given short course steroids either IV or orally, and many of these cases had either partial or complete recovery of the optic nerve injury. These are some of the examples that you can see that the third nerve is enhancing as compared to the opposite side. This is again phase contrast and SW imaging, which shows intraneural hematoma in the third nerve. If you can see that the one side of the external extraocular muscles is atrophied as compared to the opposite side extraocular muscles. Another example of the third nerve enhancing as compared to the left side, and one more example of the third nerve enhancing on the left side as compared to the right side. So this was a good prognostic or a diagnostic feature that we had developed in-house. This is the largest series of oculomotor nerve injuries which had isolated oculomotor nerve injuries without any head injury, with 26 patients in these cases. 6 of these cases had sphenoid fracture and they were all operated, and all of these with sphenoid fracture had complete recovery in their ophthalmoplegia. So this concluded that surgical decompression had a significant advantage in case of fractures which lead to oculomotor nerve injury in these cases. There is an algorithm which has been developed for the sequence of improvement of the optic nerve, oculomotor nerve. An ophthalmologist is going to speak after me and he might disagree. But the algorithm is that medial rectus followed by inferior rectus followed by superior rectus and last inferior oblique recovers. The reasoning for this that they give is that most of the work that we do in this era is a convergence, because we look at iPads or phones most of the time. And so the most trained muscle that we have is the medial rectus. And that tends to recover faster as compared to any other muscle. And obviously, looking downwards is the second most important. Looking upwards is the least important. And so superior and inferior oblique tend to recover the least. However, there is no evidence to support this. This is just a theory that has been developed. This is the treatment algorithm for third nerve. That is, if there is a sphenoid fracture, then surgical decompression is done. If, however, there is no sphenoid fracture, then steroids can be given for these cases. And especially in case of pediatric cases, very, 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 very important that you patch the nerve so that the patient does not develop amblyopia in these cases. If patching is mandatory in pediatric nerve injuries, steroid therapy will lead to some improvement in these cases. And if there is mild traumatic head trauma, even if you don't give steroids, these patients might actually improve in these cases. So MRI CIS 3D, susceptibility weighted imaging, and our own post contrast imaging are good because they can visualize the oculomotor nerve. They can show a blooming artifact if there is an intraneural hemorrhage, or nerve bulkiness on Fiesta or 3D Fiesta will confirm that there is some edema in these cases. This is a complete review of all the optic oculomotor nerve injuries that have been reported. A very important factor that is to be understood in this, that the ptosis recovery is much better than the extraocular muscle recovery, which is much better than the pupillary recovery. Pupillary recovery is the worst among all of these cases. So key takeaways from oculomotor nerve is complete vascular workup is non-negotiable in these cases, because you might miss an aneurysm and lead to catastrophic complications in these. A sphenoid fracture is basically a surgical emergency for oculomotor nerve, and treating these will lead to good outcomes in oculomotor nerve outcomes. CIS 3D, SWI, or contrast enhanced MRI will help to prognosticate the patient and advise him on further workup. Pupillary recovery is the hardest, and so expectations have to be set regarding the same. Delayed onset is actually good because these may actually improve after steroid. So if I can leave you with one image, I will leave you with this one image, that the eye is the only part of the brain that you can see, and you should protect it with the same urgency that this third nerve is being compressed by the posterior communicating artery. This is a very, very beautiful sequence that I had managed to get. The third nerve is going from the mesencephalon, and this is the IC, and it is compressing the third nerve. Very, very representative of the same. Thank you for your attention.
Thank you, Hers. You presented very nicely, as usual. As always, you present. And this is very insightful overview. It's very insightful overview of the optic and oculomotor nerve injuries. And it's a critical topic that bridges the neurosurgery and ophthalmology. And we have next, we'll take questions in the last. And
yes,
we have next speaker. I'll request Dr. Subhas Kanti Konar to introduce the next speaker.
Yeah, thank you. First, nice talk. You have given nice overview.
sir.
So next speaker is Dr. Susang Balarao. He will be covering about the ocular trauma. Sir, you can start.
Okay. So hopefully my slides are visible and I'm audible.
Yes,
Yeah,
sir.
Yes. So I'm Sushank, cornea consultant from LB Prasad Eye Institute, Vijayawada, and I would like to thank Neurotrauma Society of India and All India Ophthalmologic Society for giving me this opportunity. So I'm really grateful for this, and I have no financial disclosures. And for the sake of simplicity or better understanding, I have divided my presentation under the following headings. Like first, I'll talk on terminologies, classifications, and scoring system we use in trauma. Then on approach towards a case of ophthalmic trauma, and then about management strategies, followed by post-operative treatment, rehabilitation, and something about collaborations and preventive strategies. So firstly, like terminologies, usually ophthalmic trauma is divided into ocular and extraocular one. The ocular trauma classification, we use Birmingham's eye trauma terminology for ocular trauma. It can be either open globe or closed globe. And when it is closed globe, it can be contusion or lamellar laceration. And when it is open globe, it can be either rupture, laceration. And in case of laceration, it can be either penetrating, perforating, or those who are associated with intraocular foreign bodies. So coming to classifications, Dr. Ferenc Kuhn and Piramisi they proposed the classification in 1997, and it can be either open globe or closed globe. First, I'll go into the open globe. It can be either rupture, penetrating, intraocular foreign body, perforating, or mixed one. And we grade it according to visual acuity. When the visual acuity is greater than or better than 20/40, it can be A, or and when it is around light perception, it can be graded as E. So pupil, as Dr. Harsh already explained it very beautifully, like it can be positive when relative afferent pupillary defect is present in affected eye, and it can be negative when RAPD is absent in the affected eye. Coming to zones of open globe injury, it can be either isolated to cornea and limbus, that is zone 1, and this is a picture showing the zone 1 injury when it is isolated to cornea and limbus. These are two pictures. Then followed by zone 2. Zone 2 is from limbus to 5 millimeter posterior into the sclera. And when it is posterior to 5 millimeter from the limbus, it is called as zone 3. So periorbital injuries can be classified into simple, composite, complex, or isolated bony. Name itself explains, like simple when only one layer of soft tissue is involved. Composite when more than one layer of soft tissue is involved. Complex, it involves multiple layers, and it can be isolated bony involvement. And each one can be classified into localized or extended based on their extent. Coming to scoring system, we use this to predict the severity of ophthalmic trauma, and the ocular trauma score was proposed by Dr. Ferenc Kuhn, and he explained this in two ways, like in two steps. In first step, we just need to determine the raw points. Like when the visual acuity is NLP, the raw point value is 60. So based on the visual acuity, he has allotted the scoring system. And then if these things are involved, like if rupture is there, then we have to subtract 23 from the score system. If end off is there, then minus 17, perforating injury minus 14, and accordingly. And if there is none of the pathologies are present, then visual acuity itself determines the ocular trauma score. Coming to step 2, we just need to sum up, and he just graded it into 1 to 5 grade, and when the sum of point is 0 to 44. So basically this is used to predict the visual acuity, or maybe to predict the final visual outcome after ophthalmic trauma. And there are 77% chance we can predict about the final visual outcomes using the ocular trauma score. So coming to approach towards a case of ophthalmic trauma. So like other cases, here also proper history taking is important. We have to ask about the type of injury, mode of injury, mechanism, when it happened, the duration has passed, everything we need to inquire about the injury. Sometimes patient gives injury with foreign bodies, so we may need to inquire in detail about foreign body to decide about our course of the treatment or course of the surgery. And sometimes patients are not able to give the detailed history. We may need to take help of some Google images. I'll show in some coming cases where I use some Google images. Followed by that, we just need to go through the systemic evaluation, check for vitals, consciousness, systemic illness, and any medications history or drug allergies. Also, we just need to inquire about last solid or liquid intake, because we need to plan. If we are planning surgery under general anesthesia, these points are important to plan. Then subjective test of visual function, like visual acuity and confrontation and color vision for optic nerves are already mentioned about this. And objective test of visual function, then pupil shape and position, this also already being explained by sir nicely. And then other tests like extraocular motility, sometimes some extraocular muscles are trapped into the orbital injuries. Then this motility test just tells us about how which muscle is entrapped and how we need to go ahead with the treatment. Then external inspection like associated adnexal injury, hemorrhages, or step deformity of orbital rim, subcutaneous emphysema or periorbital emphysis need to be checked on. Slit lamp, this is the most important and best tool we have to examine the eye. So I just go a little in detail about slit lamp examination. Or here we have to check about the adnexa like lid defects or canalicular injuries. And going ahead in conjunctiva, we need to check about the subconjunctival hemorrhages, foreign bodies or tears. Sometimes foreign bodies are lodged below the conjunctiva, and there are chances we may miss it in cases of subconjunctival hemorrhages. And after that, we just need to go ahead with the step-by-step examination of sclera. Need to be looked for laceration, uveal prolapse, or infection, or any foreign bodies. In cornea, we need to look for any tear or like full thickness or lamellar laceration. Also, we need to note about the size, shape, extent of tear, any uveal tissue prolapse or presence of foreign bodies. And then Cedar test, like here we use fluorescein dye to be placed into the eye, and just we need to check on the leak of aqueous. If there is any small tear, we should not miss that. I'll show you a video clip how we used to do it. Like we just put fluorescein dye and you can see the small amount of aqueous leaking from the small wound. We should not miss this. So this is an important test to know the integrity of the globe. Also, we should look for presence of any secondary infection. Then anterior chamber, look for inflammation or hyphema or any foreign bodies. We can miss these foreign bodies in cases of severe inflammation or hyphema. Always check for angles of anterior chamber. Like we need to check it with the gonioscopy or examination of the patients in extremes of cases. So iris need to be looked for any irregularities, dialysis or iridodonesis. Like this was the patient of severe trauma who had iridodialysis, severe iridodialysis in the inferior half. And his pupil is almost like gone. Then after that we repaired it, and patient got his pupil back, and then we implanted some lens and patient got his vision back. So the lens should be looked for in clarity, capsular integrity, and position, as there are chances of subluxation or dislocation in cases of ophthalmic trauma. So retina dilated fundus examination we do if possible. Like some cases the view is not that great because of hemorrhage or media is not clear. So in those cases B scan need to be done to check the shape of the globe as well as is there any echo or infection into the vitreous. So before going ahead to the management strategy, I just need to focus on these two things always and always examine the other eye status. And this is the most important part. Like we have to counsel the patient and his caregivers regarding the prognosis and what we are doing. So coming to the investigation, we also have some investigations to diagnose the cases of ophthalmic trauma. Like we do slit lamp photography, B scan, anterior segment OCT, CT, and MRIs are explained nicely. So I'm not that expert like you all in that field. So, but slit lamp photography, we used to do it to explain the patient about the treatment option, prognosis, and to document the case as well as it will be
अनिल
useful
आईपैड
for
एडिशन में डाला है क्या प्लीज कीप ट्राइंग
follow-ups.
प्लीज कीप
So we can
टाइपिंग
explain the
क्वेश्चंस विल
patient
बी डिस्कस्ड इन
how the treatment went,
हाँ वही है
and just explain the prognosis.
कौन सा है
We can just explain the prognosis. So am I audible or?
Yes, sir. Yes, sir. You continue, sir.
Yeah, you are audible.
Okay. Okay. So second investigation is a B scan or ultrasound. So we use it to know the status of the posterior segment, especially when the view is poor or absent, and also to search for foreign bodies. Like this is the case, and in this case the B scan was done. This is the one case where you can see the foreign body in the B scan, and intraoperatively we can see how the metal foreign body looks into the during the surgery. So one more tool which we have nowadays is anterior segment OCT. This is a non-invasive test which we use to see the angle structures and all anterior segment. It is useful to diagnose the foreign bodies into anterior chamber or angle. Like this is the case. Foreign body was taken from the anterior chamber, diagnosed on the anterior segment OCT, and then this is how we removed it after doing the surgery. So it was a needle came out, and when
सर तो अभी ज्वाइन किए
next one is a CT scan, like foreign bodies, especially metallic or glass one. And as sir mentioned, it is very useful tool for optic canal fractures or optic nerve compression. Then last investigation we have is MRI. Use it for trauma or traumatic optic neuropathy and optic nerve injuries, but definitely it is a metal specific. So better to use for soft tissue injuries and non-metallic foreign bodies. So sir has shown all nice video and all pictures. So coming to management strategy, this is the trauma care pathway which we follow whenever any patient with ocular trauma comes to us. So we just activate our team, we just do basic workups and the history taking. And if the life-threatening condition is there or any systemic problem is there, it should be managed by polytrauma team. We used to refer it to the multi-specialty hospital with which we have few MOUs, and then they treat the polytrauma, or combinedly we can just treat at one hospital. They have microscope also, so simultaneously we can treat with the team involved. Then if there are open globe injuries like corneal, scleral or lead laceration, then that should be treated at the earliest. And the closed globe injuries, as I mentioned, hyphema, traumatic cataracts, ulcers, and TRON need to be managed by trauma team and subsequent management of complex cases with all colleagues like retina and all plastic team. Everyone need to be involved. And if there is a traumatic endophthalmitis or blowout fractures, complex lead lacerations involving canaliculus, traumatic retinal detachment, or posterior dislocation of lens or intraocular lens, it should be managed along with the subspecialty clinics, colleagues. So TRON cases requiring optic nerve decompression, I think we are going to have a nice lecture after this talk regarding the decompressions and all. So I'll not go into detail, but definitely you guys really help us a lot in treating those conditions. So this is what we do as a pre-operative management, and I want, if any patient of trauma comes to you, to do these are some basic things. And most of the people we have done survey also, so most of the peoples have various practices, someone using drops, someone using many things to stop that. But what we use in trauma societies, or what we used to tell everyone to do, first that I need to be shielded, and then we have to stop any topical medications. No topical medications if the globe is open. This is what we follow. We used to give oral antibiotics and analgesics, what are suitable for that age. Mostly we use Ciplox 750 tablet, as we noted better penetration of that drug into the vitreous and cavities. And this is the last thing, like tetanus immunization, we used to do in all cases of ophthalmic trauma. So I just want everyone who is going back from this to take this message. Other eye need to be examined. I'm stressing it. Counseling need to be done, and tetanus immunization should be checked. These are some videos of our surgery. Like this is the first one where a fish who came out of the eye, and here I use Google Images because parents were like they were not aware what their kid has used during that fish hook and all that. So it was an 11-year-old kid who came to us with the fish hook in his eye. And when we asked about the type, because based on the type we have to manage the surgery, in some cases it was stuck. So in this case, we need to expand the incision and took out that fish hook. So this was the barbed one, and the second one is a barbless. The simply it is coming out, and just need to suture that one. The third one was a limbus tear. The fourth is a complex injury where all cornea, sclera, trauma was involved. And the last one is the simple corneal tear where we are just suturing the corneal tear and later we deal with the cataract surgery. And this was the interesting case where there was history of working on a sewing machine. That's what the history female gave, and this needle was not visible unless until we did anterior segment OCT. And so based on that AS OCT, we planned our surgery, and later this needle came out. So nowadays we are using endoscopes also to take out some anterior chamber foreign bodies. We have published few reports regarding this, and that is also working well for removing foreign bodies. Coming to post-operative treatment, simply we give systemic analgesics or broad spectrum antibiotic for at least 1 week. Topically, we start antibiotics. Like mostly our preference is moxifloxacin or chloramphenicol and any cycloplegic. And steroids we used to give really with caution because there is always a risk of infection when we are giving steroids. So we need to really monitor them very well about the infection, as well as there are chances of intraocular pressure rise if we give them steroids. Also, we advise patient to defer sports or bike riding. As sir mentioned, most of the injuries are during bike riding and all in India. So fortunately, we drew bike for longer time and we are safe. Now we are feeling that. And then protective eyewear need to be worn at all the times. So these sutures, whatever we are placing, we used to take them out at the end of 3 months unless until they are loose or broken, which we take out immediately. So whenever there is a sign of stromal healing, we just start the suture removal. Usually it takes 3 months. And on follow-ups, we just need to check uncorrected visual acuity, best corrected visual acuity, intraocular pressure at each and every visit. Usually we follow up the patient on post-operative day 1 week, 1 month, 3 months, and 6 months, and yearly. So after removal of the suture, we just need to do the refraction or contact lens trial, and patient used to get better vision if it was a good prognosis eye. And visual rehabilitation can be done with optical keratoplasty or with or without intraocular surgery. Again, normal eye need to be screened for sympathetic ophthalmia every time. So coming to last part of my presentation, that is collaborative or preventive strategies. We need to collaborate with polytrauma centers, academic institutions, non-government organizations, other tertiary centers, and multi-specialty hospitals to tackle any life-threatening emergency. And obviously, imaging center collaboration is must to know about the details of the trauma. Also, nowadays, these insurance companies are taking ahead. We need to just collaborate with them. And we need to conduct few training programs and fellowship regarding ophthalmic trauma. And we need to train all residents and all practicing ophthalmologists regarding the basic things of trauma. And obviously, prevention is better than cure. And we need to run public awareness and education campaigns. And we need to partner with school, workplaces, sports clubs, and community organization and organize annual awareness events like Eye Safety Day or Eye Injury Prevention Month, like that. And we need to promote use of protective eyewear. Most of us are not using. In US, I'm seeing almost all people are using workplace safety measures. They're using goggles. In India, it's like we need to really work on this area, and then sports safety promotion need to be done. Then research, we need to continue the research and publish all our reports as well as the treatment strategies. And then we need to focus on government policy and advocacy. Also, first aid training for public need to be given. So coming to end, like necessary preoperative assessment and investigations play an important role in the management. Principles and goal of the surgery management should always be kept in mind. Proper surgical technique with appropriate precautions, during the surgery is the key for best outcomes. It's not always the lost eye. We can win the battle at any stage of time if we do it well. And counseling the patient and his caregivers about the prognosis. Again, I would like to stress the importance of counseling, because so many things like medical legal things are coming up. So never ever forget to counsel the patient and his caregivers. And patient should also know about what we are doing. And other eye we need to protect every time. So we need to examine it every time. So we practice these things at our center, and we run dedicated eye trauma centers at our Bhubaneswar and Vijayawada campus. And we'll be having a small workshop, a 2 days workshop with some wet lab practices and hands-on sessions in January. So I would like to invite you all, and all delegates or any residents you are having. So again, thank you. Thank you, everyone. Thank you, Neurotrauma Society of India and AIOS, and on the behalf of APOTS and Ocular Trauma Society of. Thank you.
Thank you, sir, for a nice and comprehensive talk. Questions we'll take at the end. So I'll invite Dr. Arun Srivastava, sir, Professor of ACPJ. Sir will be dealing with the operative strategies, endoscopic and microscopic. Sir, can you share your?
Yeah, if it's the option is not visible on my screen for sharing the.
सर वो थोड़ा राइट में है, जस्ट वो लोअर बार को जस्ट इफ यू कुड स्लाइड इट टुवर्ड्स द राइट ना, वहां जस्ट आफ्टर चैट रिएक्शंस एंड देन शेयर.
कहाँ पे? Yeah. So I think my slides are visible.
Yes, sir.
Yes, sir.
Visible. Go for slideshow. Yeah,
Yes, sir.
perfect. Yeah, thank you so much, team NTSI, led by Professor Sumit Sinha and very effectively managed by Deepak Kumar Singh. And thank you, Anil, for choosing such an interesting topic. Even I am learning. I learned many things from both the speaker, Dr. Harsh. Thank you so much, and Sushank, for actually teaching me as well for to many things. And the thank you for reminding us for the tetanus toxide injection in cases of traumatic. Even I was missing that. So sometime we start a journey, and that journey is unprepared, unexpected, and sometimes it's accidentally we start the journey. So it actually happened with me. This beautiful girl presented to us with very significant visual deterioration, left eye PL negative and right eye PL positive, with the background of benign intracranial hypertension. Because as Hers knows that we started our trauma center from last 6-7 years. So before that I was dealing with benign intracranial hypertension. So in 2012 I encountered this girl, and then after discussing with my neuro radiology and ophthalmology colleague, with the help of my neurotology colleague, I operated upon her on the right side. And this girl improved significantly, and then she's having serviceable vision in right eye, and the left eye is hand movement close to face. So my journey started, and I started doing many more cases like this girl, professional in painting, and she also presented with very significant visual deterioration and responded to the endoscopic optic nerve sheath decompression. And she also now pursuing her hobbies and her passion. And similarly, this girl is now doing engineering, and they all are in touch with me, and they keep on messaging me their well-being and their further development. So I'm really will be very happy one day if I see this girl as an IAS officer, an operated case of endoscopic optic nerve sheath decompression. So, dear friends and colleague, I'll be talking about this beautiful story about my journey towards the optic nerve decompression, which I started doing for benign intracranial hypertension and venous sinus thrombosis, and then from last 5 6 years, I'm doing it for the traumatic cases as well. So thanks to my team who keep on making this happen, and then they keep on updating me with the progress of my patient recently operated in March 26, and patient is having improvement in the vision, and that encourages you to do more and more these kind of cases. So for me, it's mainly fitting for the benign intracranial hypertension, that optic nerve decompression actually it elevates the sorrows and wounds, and that heal only when we touch them with compassion, as rightly said by Jack Confield. So what I was doing between the when the Harsh and Shushank was giving the talk, I was actually hiding many of my slides. So they made my life very simple. So evidence for treatment, as Harsh nicely explained, that observation, steroid to optic canal decompression. Even after the systematic review, things are debatable. So what we follow here at SGPGI, that the emergency or urgent indication is when there is a orbital compartment syndrome, and it's mainly because of the hematoma. Then if there is a obvious radiological evidences showing optic canal compromise, displaced fracture fragment, and optic nerve sheath or hematoma around the optic nerve sheath, they are the clear-cut indication for the surgical intervention, and very beautifully described, and with a lot of evidences and paper by Hirsch, that if the medial wall fracture is there, if you understand what are the cases you can address with the endoscopic route, and what are the cases where you have to go through the transcranial route. So there are two another routes was mentioned by Harsh. One is transorbital, and one is my ophthalmology colleague will be able to recall. Sushank will be recalling that there was a time when they used to do these approaches through transconjunctival approach. So the evidences, as I was mentioning, it's actually they are not having strong evidence because of the presentation, the various factors which determine the outcome. So surgery is indicated in straightforward cases as mentioned here, and then you should be knowing what are the factors which are going to influence your outcome. So the baseline vision, the very logical thing, if the vision is good, you will have good outcome. If you are doing early surgery, your outcome is going to be good. If radiology is favorable, if the nerve has not, transected, if there is only small fracture segment, not compressing the nerve much, the hematoma and other things are superficial to the sheath, and then these are the going to be a very positive factor for as far as your outcome is concerned. And obviously in other factor, like if associated injury, like there's a severe head injury and the interior changes, the vision is rapidly deteriorating, and other factors related to the patient. So keeping everything in mind, what I try to give to my patient is encouragement and hope, because evidences are very, very confusing regarding the optic nerve sheath decompression. So I'll be starting with endoscopic optic nerve sheath decompression. And we understand that we are going from the medial corridor. So we can address this lamina papyracea to decompress this intraorbital part of the optic nerve. If there is a hematoma, we can remove this lamina papyracea, and as well as we can remove the periorbita we can open, so that some amount of fat can bulge out in this cavity. That will also help in elevating compression from the intraorbital part of the optic nerve. Then this is the part, this is the very difficult part, the optic canal. So optic canal, as if the fracture is on the medial side, we have a endoscopic route. If lateral side, we have the microscopic route, transcranial route, sorry. And then this segment, from one side, we understand as a circle, will be able to open 180 degree, or maybe slightly more than 180 degree. But transcranial, we have more scope if we are removing the optic strut. I'll be discussing about that part in later part of my presentation. So first, just to explain the steps, because in trauma, even Hers will agree that in trauma cases, the endoscopic cases is not as clean as these kind of cases like benign intracranial hypertension. So just to orient with the steps and how these steps are different from normal pituitary surgery, endoscopic pituitary surgery, I have chosen this video. This is the first case which I was mentioning about. So, a 15-year-old girl, she presented with progressive painless deterioration of vision, as I mentioned about. So, there are some signs related to the benign intracranial hypertension, like flattening of the sclera and then the tortuous optic nerve with partial or sometime empty cella, and then halo sign around the optic nerve. So optic nerve, so we always get a CT scan. You can appreciate concha bullosa on the right side as we were about to operate on the right side. So you see, we are going to out fracture the inferior terminate. This is a very simple step to give you more room toward the coena part of the corridor. Then we are going to perform the vertical laminotomy as we are dealing with the concha bullosa. So this is a very simple technique. You can completely remove this middle terminate if it's coming in your field. But in concha bullosa, what we prefer the lateral half of this middle terminate to be removed up to the level of ground lamella. Now you see, this is something different what we neurosurgeon are not doing routinely, but I think we should be learning this particular part because it's very, very important. We want to land on the lamina papyracea. So here what we are doing uncinectomy. And this has opened the maxillary antrum. Then bullectomy. This is the classical method. It will bleed for some time, but with decongestant patties and all, it will stop. Now we are going to open the sphenoid sinus. Now the classical pituitary steps, and then we have gone inside. So this case was having many surprises for us. I'll tell you later. So we are cleaning the bones of the sphenoid face. And then as Hers has mentioned, for these cases, you have to do the sphenoidal opening as well as ethmoidectomy. So we are connecting both the areas, and then you can see the ICA in this case is what dehiscent, and you have appreciated MOCR and LOCR. So as Hers was telling, LOCR exposure is mandatory because if you're not exposed that area, you'll not be able to see the optic nerve in full course. So here we are drilling the orbital apex area. The bone in this area used to be thick. So I'm using my left hand. So and new drill bit, continuous irrigation of normal saline at room temperature, sometimes cold, medial to lateral or lateral to medial, whichever ergonomic suits you, but you should be elevating the bone always away from the optic nerve and the medial part of the globe. So stop and go technique is very, very important. And you see the drilling is more toward the superior aspect because as mentioned, the infrolaterally you'll get the Infromedially, you'll get the ophthalmic artery. The bony clearance should proceed up to the area of zonula absent. And that is how the optic nerve looks after a complete decompression, osteal decompression. Now we are doing durotomy. So durotomy is done medial to lateral, and this stroke should be single and should come up to the zonula absent. And then here we are also trying to cut the arachnoid layer so that CSF egresses, because we are dealing with the benign intracranial hypertension. And here the pathology is intrinsic, not extrinsic like trauma. And this will respond with CSF egress as well as glial scarring. So that is going to help this patient, and that is how this patient was benefited. We have performed the surgery on one side. The vision improved significantly on the right side, and left side also it has improved to hand movement close to face. Now I'm going to show you a case where both the nostril were utilized and both the optic nerve was decompressed. So almost same steps. Here we have already out fractured the inferior turbinate. Uncinectomy was not done because we were having very roomy lateral compartment. Lateral compartment means lateral to the middle turbinate. So we are doing the bulectomy. And after bulectomy, the same. Now we have landed on the ground lamella. So the medially we will open the sphenoid ostium, and then we'll go inside the sphenoid sinus. And then we will connect the sphenoid ostium with the posterior ethmoidal area. So that is how now you can see the lamina papyracea. Now we are doing the mucosal elevation on the opposite side. You can appreciate the bony keel, and then after a posterior septostomy and removing the face of the sphenoid sinus, we are able to expose both the optic nerve area. So now you can appreciate this is the after removal of the lamina papyracea, you can see the periorbita with orbit. Now again the same steps, drilling the thick bone near the zonula absent, and then medial to lateral or lateral to medial, whatever ergonomic suits you. But the only thing is the drill should be with a new drill bit, stop and go, with good irrigation of normal temperature or slightly cold saline. And when you are using the instrument like cottles or any other elevator, it should always be away from the optic nerve. So the complete osteal decompression is achieved. Now we are good to go with the durotomy. Sickle shape knife actually helps single stroke from medial to lateral on the superior aspect to avoid any injury to the ophthalmic artery. The same thing can be performed on the opposite side, medial to lateral. I know I have hooked the dura nicely with the sickle shape knife, so I'm not worried about this bleeding around the operative area. Then put some Surgicel. Never try to stop this CSF egress. Just put some Surgicel. This will help in the glial regeneration and scarring of that area, what is explained as the pathophysiology behind improvement of these cases. So now I'll take you to the one traumatic case with this background. You see there is a fracture of the roof of the orbit, fracture around the fovea, and this indicate that this optic canal is shattered. It's fractured. So it is a right-sided optic canal and fovea area fractured, and there is a other fracture. So in this case, the vision gradually deteriorated to PL positive, and then we proceeded with the endoscopic decompression of the optic nerve. So right-sided approach, same. You see that we have out fracture the inferior terminate. We are out fracturing the inferior terminate. Then we are cutting the middle terminate up to the level of ground lamella. Now uncinectomy. Now we see the field is not as clear as the BIH cases because they bleed, and you will appreciate that the skull base around the fovea and clinoid is moving whenever we are doing any maneuver. So you will appreciate that movement. As Hers was rightly telling that you cannot punch it out. See, it's moving. This skull base is moving. See, it's moving. So in these cases, you have to be very, very careful. And I've been lucky that I've been trained with these BIH cases. Then I started doing these traumatic cases, and that really helped. So we are locating the sphenoid ostium. Now again, as I said, now sphenoid sinus and posterior ethmoidal cell will convert in a single compartment by clearing the face of the sphenoid sinus and then taking out the mucosa from the posterior ethmoidal cell. So in trauma cases, the debrider and other things should not be utilized because sometimes prolapse fat from the orbit start coming, and that can increase the morbidity while performing this optic nerve decompression. See, this is the posterior ethmoidal artery. It was already severed and was bleeding, so it was coagulated and completely cut. And you see this movement of the base near the fovea. See, so once we'll engage the upcut, see, we are just crushing the bone there, but we are not, with the upcut, we will not pull the bone. See, so with this upcut, you see, this whole segment is moving, right, with each and every punch, but we are crushing the bone and leaving it there. So we have to avoid our, impulse of pulling out the bone along with the crushing. So after many hours, we were able to see this fracture segment. See, this is the fracture segment over the optic nerve. And as Harsh was mentioning that durotomy should be done in cases of trauma or not. So what I understand, the pathology in BIH cases are intrinsic. So in those cases, I prefer doing durotomy and sometimes arachnoidal dissection as well. But in trauma cases, in most of the time, there is no intra sheath hematoma. I just do the osteal decompression and then I stop my surgery. But here you see this bone is further impinging even we have removed this fracture segment. So we have to remove this bone as well to completely alleviate compression from the optic nerve. And it has been removed. So this completes our surgery, and this patient, the vision improved significantly in 24 hours and it was like PL positive too. He started counting finger. We were not able to take him to Snell and Shard, but in follow-up, he's having good vision in this right eye. So again, as I said, only surgical, nothing else, because if you are putting gel foam or something else on that, you are actually putting and causing compression over the nerve. So whatever I gained through this VIH cases, I tried to publish, I tried to make my own series, and then I applied in the traumatic cases. So coming to the transcranial optic nerve sheath decompression, I would like to highlight very important fact that before starting the transcranial decompression, we should be knowing the surgical anatomy of the anterior clinoid process. So we know that anterior clinoid process are having three bony attachment: the base, the anterior root, and the posterior root. So once you are doing posterior orbitotomy, means if you are removing the posterior most part of the roof of the orbit, so you are actually disconnecting the base. So this base disconnection helps you in this base disconnection shown by the black arrow, disconnect the first bony connection, then actually this anterior at least 180-degree decompression will be done. So if you want more decompression, you have to remove the posterior root as well, right? Which is formed by the optic strut. So this is an operative photograph. This is the anterior root, and this is the optic nerve. This is the optic strut. So I'll take you through one of our traumatic case on the left side, as rightly mentioned by Harsh, the lateral fracture, roof of the orbit fracture, and the frontal sinus fracture. You need to come from the transcranial root, and then you need this kind of positioning. If you want to add something else like contusectomy or any other procedure, you can make this flap as a trauma flap. So you need high-end microscope, high-speed drill system, microneurosurgical instrument, and if possible, the monitoring always helps in all and every cases of neurosurgery. So here we have done the left frontotemporal craniotomy, and what I'm trained in doing the zygomal lowering, so that gives me a very nice trajectory toward the base. And then posterior orbitotomy. So what I'm doing, this posterior orbitotomy is actually taking out the base. That is, the base has been removed. You can appreciate some fracture segment was already there. And then what I want to suggest, that if you can cut the 7 millimeter thick, this orbitomeningeal band, usually 7 to 7.2 millimeter, this will give you a nice leverage to take out dura from this clinoid, which is actually over and forming the anterior root of this optic canal. So more than 180-degree decompression has been done. If you want more, you can remove this optic strut. So another case on the right sided. So again, a tailored orbitotomy and then removal of the anterior root. That completes your bony decompression. So other possible approaches, as I said, these are transconjunctival and transorbital. I am not having first-hand experience of using these approaches. So I would like to conclude that the endoscopic optic nerve sheath decompression is an elegant surgery and requires one more step over and above routine endoscopic transcondylar surgery. And the lateral approach, that is lateral to the middle terminate, we should be learning and we should be practicing. And coming to the transcranial optic nerve sheath decompression, I think, as per me, we require a proper understanding of anterior clinoid process anatomy understanding. And I would like to acknowledge team neurology led by Dr. Ravi at our place. Neurology team led by Dr. Jayanti Kalita, team neurotology by Dr. Ravi, and my ophthalmology team, radiology team, and obviously the neuroanesthesia. Thank you so much for your patient listening. Thank you.
Thank you, sir, for the detailed demonstration of endoscopic approaches and microscopic approaches. All the videos are nice. Sir, I have one question. Like, what protocol you follow in HCPJ? Like, after trauma, do you do a CT? Like, you told that orbital compartment syndrome is the one of the indication of surgery. What imaging protocol you follow?
Actually, I think what we are following is what Hers has nicely enumerated. The thin cut CT scan at the level of optic canal, coronal cut are very, very useful, but we are putting everything, the axial, coronal, and sagittal cut, 3D reconstruction. And if there is no foreign body injury, if there is no foreign body injury, we are also going for the MRI with heavy T2 weighted images like cis sequences. And then we see, because the soft tissue component are better appreciated with MRI, and heavy weighted T2 sequences, they delineate the muscles from fat and to the optic nerve. So as you rightly pointed out, it's actually it's like a immediate indication, urgent indication if we are having any intra-orbital hematoma causing compression over the optic nerve and leading to deterioration in vision. So that is well picked by the MRI. And for CT scan, a thin cut at the level of optic canal. So that is what we are following at our place.
Thank you, sir. Any other questions from audience? Because there is no questions in the chat box.
I think there was many question for Harsh.
That Harsh has answered, sir.
Okay, answered. Okay, right. So I don't know, during my presentation, my side was showing that my internet is having some problem. So I just wanted to ensure whether things were fine or it was having some.
It was okay, sir. It was okay.
Thank you.
Nice, sir. Nicely you demonstrated the videos. Videos are very good, sir. Very educative videos.
Thank you so much. Thank you.
So I'll request panelists to give their views. Dr. Edward and Dr. Vijay Parihar.
Yeah, thank you. I think it was a very good, complete review of traumatic optic nerve as well as other cranial nerve injuries. And these are the way, most of the time, a very neglected part. So very few people are used to talk about this in various forum. So it's a really nice to listen the expert like hers and Professor Shushank and Arun sir to he has given and we have to encourage our resident and all trainee to look at these and they should learn and these techniques. Very good, very and I thanks to the Neurotrauma Society also.
Thank you.
Thanks, Anil. Thank Neurotrauma Society for giving this opportunity. I'd like to wholeheartedly thank all the speakers for the wonderful presentation. Harsh, thank you for bringing out a good overall meta-analysis and systematic review as to what is indirect optic nerve injury and what is direct optic injury, and what are the prognostic factors. And you have covered all the topics well in advance to make the other speakers easy. That's a good job. Really appreciate you for that. And the slides were crisp and clear. The takeaway from Harsh message has been there is no standard level 1 evidence, but however, there is no evidence even for the steroids. But those patients who are having a visual acuity and who have the features of direct optic nerve compression
should benefit from an optic nerve decompression, as elucidated by Dr. Arun. And the evidence stands in dilemma, but the necessity to control, do more studies that helps us to encourage to all the across institution to collaborate and make this formative assessment to assess what is the real role for optic nerve decompression. I thank Dr. Shushank from LV Prasad for a wonderful overview of what is a globe injury and what are why history is important. So I was just wondering why history is important. Is there an injury to the eye or not? But he did show the evidence of the fish hook and the needle that disappeared. So the need for, and he stresses the importance of health care protective eyewear, which is of paramount importance when we as surgeons should be careful and also while driving. Thanks, Dr. Shushank, for that wonderful overview of optic trauma and what is being done at LV Prasad Institute. I think wishing you good luck for the upcoming project in 2027. And
Thank you,
Dr.
sir.
As usual, special from SGPGI, good friend across different institutes. And thank you for elucidating on how you gained the experience. It's very interesting to see the candidates that you are in touch with and how they're communicating with you on a daily basis or progressing, also explaining the progress. Good videos to learn first on a benign optic internal hypertension, the art of cutting the dura, the necessity to go from medial to lateral or lateral to medial, and stressing again on putting the Surgicel for natural healing. That's a wonderful video, Arun. I congratulate you on the papers that you have published and also the technique for optic nerve de-roofing and delocking. Thank you once again for the wonderful session. Thank you, speakers. Thank you, Anil and Neurotrauma Society.